Great. So thanks for joining everyone today. The basic premise of this session is to equip you with the tool that you need, primarily the flow of funds in healthcare, to best understand your target in the ecosystem, right? So you have to follow the money, and how that money flows through the system is going to really help you understand what your strategic opportunity is in this space. To give you a little bit of background, you guys already know me, everybody in this room knows me. I come from the provider and payer side of the world, so I went from managing 28 clinics to 14 hospitals, 50 skilled nursing facilities, and a national health plan, mostly in the contracting and network management side of the house with the health plan, but some operations as well. During the transition from 2013 to 2014, I was responsible for the ACA or Obamacare implementation across the 28 clinics in 2 different states. So kind of the variation between Texas and California, and kind of how we had to operationalize something that we were kind of building as we were flying it, was a tremendous learning experience for me in terms of value and how you bring value-based care into the picture. In addition, I was responsible for administrating the bundle payment program for 14 of the regional hospitals here in this market, from San Luis Obispo down to Northridge, Long Beach, Riverside, San Bernardino. I said San Bernardino? Yeah, it was like crazy drive out there. Oxnard, and so forth. So I had the opportunity to kind of be in this highly volatile value-based care model. We made 1.1 million at one acute center, and then we lost 3/4 at another. So kind of marrying strategy with operations became the exercise there, and I got to kind of see another angle into the acute side and the post-acute side. And then when I went to Humana, I dealt with all lines of business, which you'll learn about managed care in terms of Medicare Advantage and commercial lines of business. Humana did not have Medicaid or ACA, otherwise known as Obamacare plans, in the markets for which I was responsible, but they're the same kind of concept. So what we're gonna do is I'm gonna follow the outline I sent over to the team, and I'm really looking to bend the learning curve here, and please feel free to ask any questions. I'm gonna go through this kind of as fast as I can while being sensitive to the fact that there's a lot of information that's going to be thrown out, so that we can have a Q&A session and dialogue and kind of hear what it is that you guys wanna know specifically as it pertains to all the things we'll talk about. So let's first talk about kind of functional areas, because this relates to how you'll be able to kind of implement your business model. So in healthcare, regardless of whether you're one provider or a huge health plan, you're gonna have 6 functional areas that you need to essentially fulfill, right? Either it's one person doing all 6 or 20 people doing half of one. So what we're doing is operations, or ops, health services. That's your utilization management. Quality, which is the value-based care, kind of metrics, outcomes. A network. I also clump contracting in there. Engagement. Whether it's at the payer side, you need to engage your patients and providers. So depending on where you are, your engagement is going to be different. And compliance. So you need all of these 6 areas in order to function. So volume to value. So basically there was a shift in the industry. I'm sure you guys have heard about value-based care, value-based care, value-based care. What the push is here, as opposed to me getting paid for a number of times I poke you, I'm going to be, as a provider, I'm going to be paid based on what quality of care I'm delivering. And quality is measured depending on what kind of provider you are in the ecosystem, whether primary care, hospitals, skilled nursing, so forth. the quality is measured in a different way. So for instance, primary care, they look at how well you are controlling the diabetes, your patient's diabetes, how well you're, what rate are you bringing women who are eligible for cervical cancer screenings to the cervical cancer screening, kind of getting that procedure done. Breast cancer screenings, colon, it just goes on. There's a long list of quality metrics which have been shown to tie to kind of better outcomes in terms of, if we catch cancer at stage 1 versus stage 4, the cost and quality of life kind of equation looks different. So that's how providers are being measured today. The managed care mindset is around managing costs, right? So containing costs essentially. So how do we provide a coordinated system to make sure that the patient is not self-navigating essentially, so that we have a coordination. This managed care is nothing new, but still has a lot of challenges and struggles. So let's talk about kind of the flow of funds. Okay, so broadly speaking, you have commercial, and then you have government. Okay, and this is at the highest level. So commercial is, there's 2 broad kinds. So employer funded or sponsored or administered, and then that goes into many different subcategories, which is beyond the scope of this discussion. And ACA, otherwise known as exchanges, commonly known as Obamacare. Okay, so these are off exchange. Employers are off exchange. ACA is on exchange. The funding mechanism and the risk associated with these 2 lines of business are entirely and immensely different. So here you're getting paid, the money comes from your employer and employee, kind of whatever the deal is between you and your employer, how much you're going to deduct and so forth. So the premiums come from the employees and employer. The premiums for the ACA come from individual premiums as well as subsidies, okay? The government line of business is taxpayer funded, and it's a huge chunk of opportunity. So when we talk about government funded, we're talking about Medicare, we're talking about Medicaid. And we're talking about duals. Duals are also known as Medis, which is basically Medicaid plus Medicare people. We'll explain. So Medicaid is a program that is administered at the state level. Okay, so it's a state program with federal matching dollars. So it's kind of, for instance, California, it's half and half. So half, each state will have a different deal with the Fed, but basically, state will spend 50%, the Fed will match 50%, and it's state administered, right? So Medicaid is state administered, 50-50. Folks that are qualified for Medicare, depending on the state, again, that's why there's such variation. It's state administered, so state gets to set a lot of the rules. 198%, let me just say poverty level, so it depends on your income and household. And it depends on whether there's a disability. So as of 1/1/14, January 1st, 2014, this Medicaid expanded in California. Not every state, not every state expanded it, but California expanded Medicaid beyond disability and pregnancy and some other kind of smaller groups to include income. So anybody below a certain income threshold, depending on the number of people in the household, they will be eligible for Medicaid today. In California, we call Medicaid Medi-Cal. Medi-Cal. Here, everything is something Cal. Cal first, Cal discount. So that's Medicaid, Medi-Cal. So when you think about Medicaid, if you think about the aid, think low income, disabled. It can be both, it could be either. Or it could be both. Medicare is something that you're supposed to have. Not sure. Is those who are 65 and older, right? So retirement, plus some additional very niche kind of populations, like, and those are a very small number of folks who qualify for Medicare who are below 65. Okay, we won't go into all that, but think about Medicare as your retirement kind of insurance. So Medicare plus Medicaid, so the frail people, those who are poor and are disabled, plus are Medicare eligible, those are the duals, and the costliest of the population. They're the smallest in terms of percentage, but the greatest in terms of expenditure. Okay. So what does this mean? How does this kind of work? How does this trickle down? So the way this happens is you have, when you look at the Medicare element, so in California, Medicaid or Medi-Cal, there's a requirement that it is administered through a health plan. Think LA Care. It's the nation's largest Medicaid plan with 2.1 million beneficiaries. So, and this is the largest market, by the way, and we're in LA. So Medi-Cal is required to be administered through the health plans. So the state will contract with that under HP as a health plan. They're also known as MCO, Managed Care Organization. And then the health plan is responsible for delivering the benefits that are required to the beneficiaries, okay? So I'm gonna draw the same line here with the Medicare. So Medicare, there are two kind of ways that the dollars flow. One is through the health plans. These are called MA, Medicare Advantage, and fee-for-service. Basically, this is the fee-for-service is the traditional Medicare, and what that is actually, that's the word, traditional Medicare, original Medicare, they call it straight Medicare, where it's administered directly. So if this is the patient, it's administered directly from the Fed to the patient, to the beneficiary, right? So you have a kind of like a Visa card, so to speak, like a passport. If you're a provider who takes Medicare, it comes directly to you, that's it, yeah. Whereas through the health plan, you have the kind of health plan benefits and their policies and procedures and so forth. So they're out of 1/3 of the Medicare population, 1/3 is enrolled in a private plan. So meaning they're getting their Medicare through a private plan. So think about the opportunity there, 1/3. Each day, we have 10,000 Americans growing into Medicare, aging into Medicare. Each day, 10,000. So 10,000 per day from now till 2030. So when we think about from time where, we sent out this invitation, we've had 70,000 additional beneficiaries in the Medicare system.
That's why they're running out of money as well.
That is correct.
Yeah.
And so that is correct. Yeah. And so when we look at the duals, the setup is similar in terms of a health plan, and it becomes very complicated with the duals because you can have your Medicare through one plan, your Medicaid through another. Sometimes you have your Medicare straight from the Fed, and then you have your Medi-Cal through a health plan. So there's actually, come 2021, there are changes happening too, and that's something that you should start. That's like a different boot camp. Okay, but this is the sweet spot. This is where if you get it right, if you get these, the characteristics of the dual beneficiaries addressed, you will be at a huge market advantage, okay? So think about your solution as we're going over this and see what buckets you fit in.
Repeat that again, please, Alex.
Sure, so the duals, essentially the Medis or those who are eligible for both Medicare and Medicaid benefits, that population is gaining a lot of attention because the expenditure is very high. And those populations are very difficult to reach. And again, long risk, that's like managed care one or whatever, is because they have an entirely different characteristic, the dual population. So the dual population, if you're able to produce solutions that will address the characteristics of dual population, which are, predominantly chronic condition management and long list of things, then you will be very successful. That's a huge market opportunity. Followed by Medicare. Yes.
Are those both free?
They're taxpayer funded.
Okay.
Yes. But there's no premium. Again, states will vary, but I don't know of a state that charges Medicaid premium. Medicare, if you get it through an MA plan, a Medicare Advantage plan, you might be paying a premium. Depends on the benefits. So you might have a zero premium product, and we'll talk about the products, or you might have, a product that's $149 a month, which is on top of what the Medicare Advantage plan gets paid from the government. So the way the government flows the dollars down is a capitation, right? So basically, let's use the Medicare Advantage as an example. There is a long kind of algorithm and strategy and data around how the Medicare Advantage plan is going to bid to the government, saying every year. And right now, bid season is actually ending in June, and it's like a big deal for all the Medicare Advantage plans. They take into consideration a variety of factors, again, kind of beyond the scope of this discussion. And they bid to the government that, okay, you know what, we'll do, let's say $1,000. And those are, for instance, Nevada rates. So $1,000 per member per month. So when you think about health plan business, always think in terms of PMPM, per member per month. Because that's how the accounting is done. That's how the dollars are divvied up. There is no aggregation of any of these lines of business, but that's why you have so many balance sheets in one health plan. Because I have a balance sheet for Medi-Cal and the balance sheet for this bucket and so forth. So always think about per member per month. That's how it's calculated. So $1,000 per member per month. I have 10,000, let's say, beneficiaries, Medicare beneficiaries who've enrolled in my plan, my Medicare Advantage plan, my health plan, and I'm saying, okay, well, I'm, federal government, give me CMS. I bid that, based on this number of factors, I'm going to be able to provide all of the care and the benefits that I'm submitting as proposal, Cairo, whatever, silver sneakers, all these other benefits. For $1,000 per member per month. And then there is a true up and, again, goes into complications as to whether they're actually able to keep that $1,000 and so forth. But let's say $1,000. And then if it's a premium plan with a premium, let's say $140 premium, then the plan gets that brand plus member premium. I'm just going to write member premium. So this is the premium from the government, this is the premium from the member, and then you'll have like your total per member per month that you gotta work with. Okay, that's capitation. A fee.
Who pays for the premium? The member does?
There could be a member premium, depending on the product.
Okay.
Could or could not. Like you'll hear zero premium, and then you'll hear not zero premium.
But not for Medicaid. That's free.
Medicaid.
That's free for the.
Yeah, it's taxpayer funded, and there is not a premium to pay, at least in California. I don't know of any state that has a premium on the Medicaid. That's correct.
So can the member choose the health plan?
Correct. Yes. But again, there's a nuance to it. So in California, once you enroll in Medi-Cal, you have 90 days to choose a Medi-Cal plan. Otherwise, you'll be auto-assigned because there's a requirement in California for you to be in a Medi-Cal plan. No longer is it fee-for-service directly from the state. Not the case with Medicare. Could be fee-for-service directly from the federal. So this capitation, this is your PMPM. This is your total PMPM. Okay. Any questions so far? No?
That
Okay.
$1,000 figure, is that, you said that's just for Nevada? Is that like an average?
Well, I mean, there's not an average. It really depends on the market. And there is this information is available. Actually, CMS, it's called Rate Book. rate book, and then you have to figure risk adjustment factor, which is something that Bruce is working on, and it really impacts the top line revenue of the health plan. So when you multiply this by a payer like, one of the big five, when you're talking about, a 3 million member plan, that adds up. Anyway, so the duals, just know that they're duals, okay?
Could you just briefly explain the health plan's role
Sure.
and everything?
Yeah, that's a great question. Health plan's role is to administer the benefits meeting this benchmark that they've set forth to CMS. Now, they could be coming below that benchmark. What does that mean? Okay. It's called medical law. It's okay. Medical loss ratio, MLR, which is a KPI for MA. It's a KPI for Medicare Advantage plans, all plans, but MLR, medical loss ratio. There's a requirement that no more than 20% is spent on administrative stuff and 80% is spent on care. So the role of the health plan, one, is to spend at least 80% on care. If they spend 110% MLR, it's none of our business as the federal government because it's a capitated deal. So I'm going to give you this much. You're responsible for administrating the basic benefits under the traditional Medicare, meaning non-health plan Medicare. And if you're going to add additional benefits, then that's going to be in your proposal that we'll review, along with what you're asking for in terms of capitation. And so payers, for instance, private plans that have Medicare Advantage have been offering things like Acu, Cairo, Silver Sneakers, which is, 24-hour gym membership, and so forth, that are above and beyond kind of outside of the Medicare requirements, but they, for reasons such as reducing costs, they've been shown to be, and attracting beneficiaries have been shown to be effective. So the role of the plan is to really be managing the care of that patient, of that beneficiary, and provide and hitting those MLR marks.
So the health plan doesn't fund the money though. The money's still coming from the government.
Correct.
They're managing it, but they're also not delivering the care. They're just the middleman.
Precisely.
Okay.
Their role is to then contract out a network of providers, which is subject to network adequacy requirements depending on the line of business. So when we're talking about Medicare, Medicaid, duals, commercial, these are lines of business, otherwise in the industry known as LOB, line of business, bucket.
For all healthcare, health providers, health plan providers, private entities, or does the state or government operate their own health plan providers?
Health plan provide, what do you mean provide?
Yeah, is it all private entities, or does the state of California have their own health plan providers?
The state doesn't have
doctors. They don't employ doctors.
Yeah, typically, but I mean, you can have like a county hospital and
With their own health plan that then would apply to their network, or
no, it
who
would be, no. For instance, but if you look at LA County MLK relationship and LA County Department of Health Services, they have a relationship with LA Care that is a public entity, and I mean, that just goes into a different kind of dialogue and structural discussion. But it's a yes and no.
Yeah, but there's not a state or government funded health plan provider that competes in the market. That's all private entities. There are.
Mm-hmm. And we can talk about that.
Yeah.
Yeah.
Okay, I'm just wondering.
Yeah, there are. Yes.
In a non-political way, could you define the differences between single payer and non-single payer?
Is
that a loaded question?
That's a kind of discussion out of the scope of this thing, but I'm happy to engage in that dialogue with you, certainly. But if you apply right now, think about all of this being merged into one. Not realistic.
Okay, you answered it.
So the role of the health plan is to then have a network of providers, which are subject to network adequacy requirements depending on the line of business. So as you can see, there is a segregation or silo in each of these buckets, even though it's one health plan. So the network adequacy, will dictate depending on what the county's designation is, whether it's a metro, rural, there's 5 designations, number of endocrinologists that need to be in the plan, number of hospitals, number of primary care, number of this and that, right? So 40 specialties and the number that need to be in the network. If you satisfy the network adequacy requirements, then you can apply to be a health plan with plan and benefit designs for the coming year. So the network is of providers, okay? In California, of course, you have to complicate things. And what happens is that, you guys, this is the area that I've seen a lot of kind of tech companies run into, and I mean, these are multi-million-dollar companies, is the California model. California is a different beast, okay? California has what's called risk-bearing organizations, RBOs. RBOs they have different names, okay? So they're called IPAs, Independent Physician Association, just confusing, MSOs, Managed Service Organization, TPAs, which actually cannot bear risk in California. So it starts differing by state. So a risk-bearing entity, what that entity does is it takes a percentage of this deal that the health plan has. So again, it depends on their contract. And let's say in an example of 86% of POP, which is percent of premium, the health plan will give to the risk-bearing organization and say, bye, in simple ways, right? Say you deal with the beneficiary, you deal with the network, there's a delegation of functions that occurs. And then for all practical intents and purposes, as a healthcare entrepreneur, as a B2B business, you need to know who has the risk for what population, what market you're after. Because if you go up to a plan, thinking it's a health plan, it's a payer, but that payer has already delegated risk to another entity, they're not interested in having discussions around certain items that do not hit that bottom line. And so what you're looking at is, remember we talked about the 80%, the MLR 80%? So there's their deals vary, but let's say 86% of the premium is passed down to the risk-bearing organization. One is right downstairs, 9th floor, Prospect Medical. There's different kind of risk. There's a global risk, and this is important to know because if you're in the inpatient market, you need to know how that risk is divvied up. So there is global risk. Yeah.
Reinsurance.
Not really, no. Reinsurance is another element that has to do with stop loss and.
But if you insure your car today, it's the same thing. If you give someone 100 to insure your car, they're going to pay someone else maybe 86 to say, hey, you're actually responsible for Alex's car. I'm not.
That's
14% to admin. Yeah.
Correct.
Yeah.
That's somewhat the concept. But what happens is a delegation of functions. So the functional areas, right? You'll have something called the DOFR, Division of Financial Responsibility, between the health plan and the risk-bearing entity, and they'll divvy it up. So they'll say, it's a long list of things, right? So this is where you learn about, if you don't already know, you'll learn about Part A, B, and D. So Medicare buckets A, B, D. A is for, think about acute, inpatient. B, just know that B is physician services, outpatient. D for drugs. So if it's not A or D, then it's, physician. And then, of course, there's a C, and that's the Medicare Advantage. So C is A plus B is C. Okay? C. So when we talk about fee for service here, we're talking about the A and the B separately administered. When we talk about the health plan, the A and the B are combined. And Medicare Part C is Medicare Advantage. Drugs are not necessarily included in it. That's a different thing. Yeah, Part D plan.
What was the B for again?
B is physician. Yeah. So if A is acute, B is physician. And I get more nuanced than that, but high level. So this is health plan and risk-bearing organization. just not a provider of care. And then, you know, the functional areas and the sub-functions and the sub-sub-sub-functions are spelled out, and then there'll be a check mark here. The risk-bearing organization is responsible for these things. I'm responsible. Typically, for global risk, meaning A and B pushed down to the risk-bearing organization, sometimes D, then you usually only have transplants and out of area carved out for the health plan. Every other claim is at the risk of the risk-bearing organization.
And this is a California example you're giving.
This is a California example, but you're seeing it in Florida, in Nevada, and Texas. And this is what's called the IPA model in Hawaii. It's been around in California for a long time. California is the most sophisticated, at the same time complex, market in terms of how we've kind of set up value. That's a different discussion. Is it valuable to have many, many people in the middle? Different discussion.
Who's got the lowest administration cost, the percentage of the total spend?
Oh, that's a big question. I actually have a long list, and I'm happy to share that with you because it varies, varies. Because if you're capitating and delegating your functions as a health plan, you already know. If I get a deal with you at 80%, as a health plan, I'm very happy.
You're buying new computers.
And other things. Having penthouses and
Champagne and.
I mean, we're talking $500 bottles of whiskey and so forth. So I mean, like, we're talking about a lot of administrative flexibilities. So the risk-bearing organization is then responsible for the functions around which you'll be selling your products. So Bruce is selling in the quality space, which includes outcomes and patient experience. He needs to know who has Part A risk. If I'm contracting with Health Plan A, especially if it's a multi-market plan, in this market, who are your risk-bearing entities at risk for Part A? And won't you introduce me to them? Because ultimately, the plan has stake in the success of the risk-bearing organization, because if they have, it's delegation, not abdication. The health plan is ultimately still answerable, but it's delegated those functions, that becomes another set of dynamics. So then the risk-bearing organization contracts with a network of providers who then are supposed to get, see the patients. Flow of funds.
This is, I don't know, procurement or whatever you want to call it, but it happens every year or?
It's an annual exercise. Yeah, so Medicare Advantage is January through June. It's like an exercise.
They say is enrollment January to June or qualification for the plan is January to June?
Good question. So bid season. So the health plan bidding to CMS, and then there's open enrollment that is October through December for Medicare. If you have a 5-star plan, your enrollment could be year-round. The only 5-star is Kaiser.
The whole system seems to be weighted towards reaction to disease or illness. Is there a plank in there for prevention?
We talk about it. We hashtag it. Whether we implement it is a different question. There's a Medicaid plan I won't name.
Okay.
Who managed to get 41% of cervical cancer screen. Big, you'll know the name. Big plan managed to get 41% of the population for cervical. So that's preventative care, 41%. So yes, you're supposed to.
Alex, expand on that. What do you mean they got them? They were able to capture the contract and the responsibility for 41%, or they were able to test 41%?
The latter. So they're able to, out of 100% of the eligible population, they were able to get 41%.
And that's a very good number, right? Or
That's
not?
a terrible, that's a ridiculous number.
Oh, I didn't know it's a terrible. I just didn't know how bad.
No. I mean, that's good. That's good. I mean,
How bad is bad?
it's pretty bad. That's pretty bad, but it's not atypical.
Okay.
Because you'll have
That's encouraging.
26% and you'll have, bad percentages. And the way that affects your top line revenue here throughout the exercise between the this multi-billion-dollar exercise between CMS and the health plan. Okay, so I'm gonna zoom in.
Sorry, Alex, one of the questions you said, if you're a 5-star plan, you can solicit all year round.
Mhm.
Is that in California or nationwide?
Nation, that's Medicare. So the way the top line revenue here works, we're all familiar with the top line revenue. Basically what you're getting here is different from what you're at the end of the day having, right? So the top line revenue, wow, what's happening? Top line revenue. So I love you duels, but thanks so much. So what's happening here is the Medicare Advantage dollars are like this. So you have what's called a rate book, which CMS already sets out depending on the county. They say, based on our experience, the fee-for-service claims, this is how much it should be costing you per member per month. The health plan will be like, okay, but plus the disease burden, which is known as, is known as RAF, risk adjustment factor, which is supposed to be the disease burden of the population that the health plan is at risk for. So the rate book is at a risk adjustment factor of 1. When I get the preventative care and I get the patients measured and all of that data in, my risk score could be as high as whatever, like 1.9. The bid I'm making to CMS factors in what I think I'm gonna be collecting as my risk score, which again depends on how well I'm getting those patients in, how much of the screenings I'm doing, how well are the encounter data. I mean, that goes on and on, right? So for instance, with a operation that is able to capture you, and you have to be careful, right? So when you're talking to health plan executive, depending on how conservative the plan is, assume that they're somewhat conservative, and don't say, oh, I'm gonna increase your RAF scores, because that already automatically tells me you paid. Where are you from? You're kidding, like, this is not right. You wanna say, because CMS will do what's called data validations, risk adjustment data, RADs, risk adjustment data validation, which is a multi-billion-dollar recovery exercise from the health plans. If they have basically to validate their risk scores, because the top line revenue is in multiples of multi-millions. So if you're getting 1,000, but then I'm telling you, I know I'm gonna, as a Medicare Advantage plan, I know I'm gonna have a risk adjustment factor of 1.9. I'm multiplying that with 1.9, hedging my bets like that. But come end of year, if my risk score adjustment, my RAF, my risk adjustment factor is not that number, then I'm going to be seeing red.
Alex, is that driven because as a plan, I say, okay, I want to bid on people who are really sick. I want to take cancer patients. I want to take people with, late stage renal issues and so on. So I'm going after a population that I expect the disease burdens to be way over 1, or I'm going for very healthy ones. So I'm going to go for 0.7s, or is that determined just by what the plan does? Or do they kind of know at the beginning, saying, I'm going after sick or?
That's a great question. So yeah, that's what the strategy will look at. Okay, county level, right? You can't cherry pick. So you have to look at the county. You have to talk at the county level, wherever's in that county, right? And so depending the way you start to kind of drive, the population type is by the product. So whether it's a HMO, PPO, point of service, fee for service, that's when you have, Medicare Advantage HMO, Medicare Advantage PPO. And those are the products which we're supposed to talk about. So basically, to answer your question, the risk adjustment factor comes from the rate book, right? And then as the plan, the intelligence that we have and the analytics that we have and what we know about the population, we're going to say, okay, well, we know that this population is going to be 1.8. But you could not get that RAF score, and it could very well be, but if your provider network is not coding properly or is not capturing that disease burden, is not bringing in the patient to, do those screenings, then you'll see 0.7 for something you've bid at 1.9. A lot of dollars. Plus star rating. In a nutshell, this is how the Medicare Advantage top line revenue is calculated. So if you're a 3-star plan, you don't get then it goes into bonuses and percentages and there's a whole different discussion on that managed care one or whatever. But that's the basic life. So if you're able to hit these spots as an entrepreneur making a business case here, then now you're talking at the highest level of top line revenue. But be careful how you talk, that you don't want to over increase your RAF scores, because why would you say that? You want to capture accurately. And then we all know you're saying increase.
God, that's crazy.
So
So it sounds like the whole pyramid breaks down when there's less illness, which lowers the RAF. If it lowers the RAF because you've estimated based on, what did you call the disease burden?
Mm-hmm.
Yeah. If that's lower, then now you're under budget, or?
well, it could, okay, so there's a difference between actual and captured, right? So the disease burden of this population could very well be 1.9, right, as a risk factor. But if that, and that, what that means is the population is predicted, right, to go into the hospital X number of times, to have a high utilization of services, and on and on and on. So if you're getting
You
that kind
budget
of
for
utilization,
that.
exactly.
Got it.
If you're getting that kind of utilization, but your risk score at the end of the year doesn't reflect what you budgeted, then you're having many negatives in the PMPM at the end of when you're presenting to your senior VPs at market reviews.
So is that like,
Which affects
if you
next
don't-
year's
you
budget.
don't hire enough renal specialists and you don't treat people with kidney failure, so the guys who are sending them, basically the government says, well, we gave you 1.9 on the assumption you're going to treat all these people with kidney failure. You didn't treat people with kidney failure. We're going to pay you less.
Not necessarily.
Not how it works. Okay.
Yeah, so you said you were gonna.
That's good.
all kinds of people.
Yeah.
You said you were gonna treat whatever, right? That's
Right.
your. But your score doesn't reflect what you're saying. Your risk, the risk profile of the population, as far as we're concerned, doesn't reflect all of that.
But you
Yeah.
actually treated, when they look at, you
Yeah,
treated
those
this cluster of patients, they didn't have as much heart disease as we think they didn't have as much, kidney problems and COPD and so on. Is that what lowers the score actually, that you're not, as a plan, you were supposed to help more people and you didn't, or?
You didn't capture accurately the conditions. So it's not the utilization that we're looking at.
That's it.
But we're looking at the end of the day, your primary care, also in the hospital, there's various ways to get RAF scores. You didn't capture that data. And so the data is a risk adjustment factor. It's not utilization of
It's
services.
documentation. You didn't document
Exactly,
it properly.
precisely. And every time there's a layer, what happens is that leakage happens of data. So I could have very well, have an actual score of 1.9, but by the time the data got up here at 0.7. And so there's various challenges. You have to make sure you're capturing those risk scores by your primary care providers bringing the patient in. Then you have to accurately code. Because when you're dealing in a capitated market, the provider is a capitation mindset. So meaning, I'm going to see you regardless of these things that I've done, these procedures that I've done. I'm just going to bill a evaluation and management visit because it's a capitated $14 per member per month Medi-Cal patient. I'm not going to sit here and do CPT2 codes. That's a traditional mindset. And so that misses the opportunity to capture risk scores at the very bottom line.
It's fine.
Okay.
I'm still processing.
Formula?
Yeah.
Okay.
Yeah.
Great. So are we good so far in terms of what are the drivers, what are the incentives, and what is it that hurts the plan side? I mean, at the high level. I'm seeing some nods, and that's good.
Yeah. A question in terms
Yes.
of the RAF. Is it possible for it to go up, given a lack of information or data that you've collected also?
No.
Okay. So. Okay.
Yeah.
Got it.
Because they all start with one.
Okay.
And that is the demographic and age. Well, it's part of demographic, but demographic and location factor into a RAF score. And then it's up to the plan to either keep that one, increase it, and they could lower it.
So the mainly like comorbidities.
Precisely.
That makes
That's not, it's not just
Not just,
morbidity,
but
but that's a
mainly.
big part of it.
Okay.
Yeah.
Got it.
Actually, there are 83. I mean, this is then we're going to HCCs, hierarchical condition coding. And there are 83 such categories, and then there are subcategories. They're each with, it's a cumulative process. So for example, diabetes with complication gets a 0.3.
Yeah.
Plus, if you have mental, if you have depression, but if it's coded as major depression, if you code it as depression, it doesn't count. That plus 0.5. And on and on and on equals at the end risk adjustment. Now the fun part is that you have to do this every year. It resets every year. Every year. Resets.
So what are all of the places that the data is stored for categorizing these patients as? Because I'm guessing it's not just diagnosis. Is it based on the treatment they've received, or is it
No, it's diagnosis.
So it's just
doesn't
diagnosis.
matter. Yeah.
Okay, got it.
The treatment part hits the health plan bottom line.
Okay.
Right. So that's a bottom line discussion. Where top line discussion doesn't look into
diagnosis.
utilization.
Yeah.
Exactly.
Got it.
Now, did I answer your question?
Yes.
Great. Awesome. And so these are HCCs, and there are new HCCs, hierarchical condition coding, that are added 2019, are going to be added 2020. There is opportunities for the MLR shift is huge. Fraud, waste. I don't think anybody's working on fraud, waste, and abuse here. But basically fraud come 2020 is going to, expenditure on fraud prevention and detection is going to move to the denominator of that MLR, meaning more administrative flexibilities, because it'll be considered as a medical expense versus an administrative expense. So a lot of things happening there. But again, so these are lines of business, okay? The pain points are different. The flow is different. You have to be able to speak to at least the basics of this. You then have the products, which, all of this is risk management, right? So you have products, which is important that you know, and they range in the spectrum in terms of their flexibility, benefit, and cost. So these are products. Even in the industry, people get line of business and product kind of interchangeable, but you should know as experts that line of business are the buckets, the business. Product is how you package that business. Mm-hmm. So you can have a Medicare plan that provides all types of these products. HMO, the next is POS, PPO I will explain, and then fee for service. This is the spectrum from, there are others too, like EPO, but don't worry about that. That's not common, and that's employer mostly. So HMO, everybody already knows, right? You have a PCP, that's a gatekeeper, and HMOs people are, at least conceptually familiar with. Point of service is a hybrid between a PPO and an HMO. Basically, you decide at the point of service whether you're going to go, in network, out of network, and kind of exercise what flexibilities you might have under point of service. Of course, as we go this way, plans become more expensive, right? Because the idea is that if someone wants a PPO plan, meaning they go to any provider without a referral, then they're likely higher utilizers, and they are they're overinsured, and so the PPO will cost more than the HMO, because HMO you have greater control. That's the concept that we're seeing PPO plans also be squeezed. Fee for service, basically you don't need a network. Wherever you go, it's more indemnity. Wherever you go, submit a bill and hopefully you'll get paid, but at least you won't have to have an authorization. So you can have, you won't see a Medi-Cal plan with any of that PPO, POS, it'll be HMO. You will see Medicare plans with a HMO, PPO, fee for service. You will see commercial products with PPO, point of service, and this, basically this spectrum doesn't apply to Medicaid, because then, as an indigent or as someone who's eligible for Medicaid, you don't have the luxury of choosing which kind of product you want. You're just going to get HMO. So that's product versus line of business. So line of business bucket, product, how you package it. And as a business person, as an entrepreneur, you need to know if you're speaking to someone who has a risk, is bearing risk for parts A and B, HMO product, and audacious risk-bearing organizations, if they're doing a PPO at capitated deal, then you're gonna wanna speak to these buckets, these products. And then, that's managed care 109 or whatever, but going into what specific pain points you're gonna address. And so I kind of wanna allow for questions. There are different type of risk arrangements. Basically, a risk-bearing organization can have Part B risk only, and the health plan will give Part A risk to a hospital, similar capitation model, where I give you per member per month to the hospital, I give per member per month to the risk-bearing organization. I could give Part A and B to a risk-bearing organization, and I could directly pay the hospitals outside of a capitated deal, fee for service, and then capitate the physician group, which is what some of the plans do here, because in California you need to have, again, a whole set of other requirements in order to even be a risk-bearing organization. Whereas in some other markets, Ovean and I could go ahead and set up a TPA and start taking risk. So let's open it up to discussion.
There's similarities between a RBO and an ACO. Can they be the same?
So RBOs participate in ACOs, but ACO models are the fee-for-service models, where you have kind of, if you think about imaginary lines, so let's talk about, you're doing bundle payments, right? So that is a fee-for-service population, BPCI, right? It's a Medicare fee-for-service population out of traditional Medicare that is used to, going to any provider, seeing that provider, skilled nursing facility without pre-authorizations, except when you first day you'll get that copay. And they're just there's no kind of utilization management controls. So the BPCI program looks to kind of impose some of those managed care features onto a population that is not managed, right? That has a passport that go anywhere. So to your question about ACOs, it's kind of trying to impose a similar model and incentivize providers by giving them upside rewards if they meet certain objectives.
And same goes for conveners.
Conveners partner with
the ACO?
No, there could be convener, there could be, but conveners, I think the way that you're referring to, those conveners are essentially helping facilitate the bundle payment program with the hospitals.
Got it.
Because
with Medicare.
And Medicare, exactly, it's a 3-way
Okay,
contract.
got it.
Yeah, it's a contract with Medicare, with the hospital system, and the convener. And then the convener and the hospital will get a 50-50 upside downside with 20% risk track, meaning you can't lose more than 20%, you can't win more than 20%. And so your distributed shared savings, which could be something I shell out to CMS or something CMS shells out to me, are going to be confined within 20% risk corridors. Yes.
For those of us with business models that gear towards prevention, I appreciate, first of all, you're giving us a look behind the curtain so we know where to target our marketing approach. But how do the preventive and maintenance type business models grab a hold,
Sure.
in that whole spectrum?
So if you look at MTM, medication management, yes, exactly, which is billable separately. If you look at that, right, there's an opportunity to bill. That's a business model. If you look at the capitation, the ridiculous $14 per member per month that a PCP will get for a Medi-Cal live. They call them lives, members, lives, patients, depending on where you're sitting. You have carve-outs of that contract. Out of that capitation, you have an incentive to bring in the member, patient, whatever, I call them members. You have an opportunity to bring in the member to perform the annual health assessment and get a $350 incentive outside of your capitation, which is supposed to be preventative a measure, and capturing risk score. That's the theory. That's the reasoning behind those extra incentives. So providers could get anywhere from $1.20 to $3.65 per member per month at the end of the year if they meet certain metrics. And this is from local Medi-Cal plan that has this incentive out. So there were 888 solo providers and small group providers that received $22 million, small number. How about the other 5,000 primary care providers in the market? So that's your opportunity.
Or will that go through the RBO? Will the health plan incentivize the RBO to carry this out? And then
Yes.
they will get the money top
Great
up,
question,
yeah.
great question. So yes and no. Because the RBO has already capitated a global deal of 80%, because Alex is so good, 80%. And so the RBO is to incentivize, because they're at risk now. Remember, the risk has been pushed down.
Yeah.
So it's the RBO's responsibility to go ahead and do those preventive screenings. But yes, there will be partnerships where the health plan will say, I'll give you $40, hey patient, incentive, gift card if you come in and, we do this procedure. We do this preventative screening. And so then there's a partnership element, yes. Because remember, delegation, not abdication. At the end of the day, the health plan's responsible. That's the top line revenue issue. If you have a deal that's tied to a percentage of premium. So your health plan deal, as a risk-bearing organization, we're looking up, your health plan deal is tied to a percentage. So if my health plan's top line revenue drops, so does mine. That's how the value chain works. And it depends on the deal.
I might have missed it. I think you already answered this question, but what incentivizes the RBO to get
It's
in
the fact
that?
that they have risk. Think about them as mini health plans. Same incentive. So they have risk, meaning if they're running claims that is way above that 80%, you're seeing parentheses in that black and white printed balance sheet. And most likely they're not capturing all the risk scores, which then if you're getting 80% of 1,000 per premium, think about if that top line premium drops, so does your top line premium. So the incentive is one, to take better care of the population by catching the cancer at stage 1 versus 4, is to make sure your top line revenue reflects accurately the disease burden of the population for which you're at risk. It's a long way of saying, don't let it drop.
Yeah.
And to, start getting, and to not get claims at the hospital, at the ER, where that issue could have been otherwise avoidable or treated at the primary care level versus at an ER. Because ER cannot turn you away. You get that bill. You will have to pay.
Wow. Okay.
That's how you end up with $3.5 trillion business at the end of the year. And so I'm gonna not do that. Any questions? Any other thoughts, response, reactions in circle?
Yeah, are there standard ways of understanding who's holding risk, or you just kind of
You gotta ask.
Just gotta ask, what's your contract? And
Good question.
Yeah, and it's kind of the way you ask, right? So which markets have you delegated risk, and what are your pain points? And you can ask what, in California, do you predominantly delegate Part B, or do you have a lot of global risk? And by the time, and then you kind of dot, and the health plan person will already jump in and give you a long response. Yeah, and you'll know. For instance, some deals, for instance, LA Care, because they're a public company, you can, change your Google search to show formats of Excel and type in, PPG, which is what LA Care calls RBOs. Go for a division of financial responsibility, and you'll find things that are out there as at least leads. I do have links for you guys to refer to. These things I've found throughout the years, and very difficult to find, where you can actually identify the groups and what the contracts look, what they're kind of, not how the contracts look, but essentially the website will tell you, and I'll share this with you. I know we're at the 3 o'clock mark. But there are some resources that I will share with you that will give you some information, some data, because when you're doing business projections, okay, so what's your market size? Oh, well, okay. I don't have data on all of the Medicare, all of the MCOs. So some states have expanded Medicaid, some haven't, some are through health plans, some are not. I could find out today's rates, but I was pulling out what hair, let's come back again. to find projections. So it's very difficult to find data, very, very difficult to make sense of it. So I will send you some resources that you can use to identify at least some of these nuggets of information.
And we start cold calling.
Yeah, cold calling. I mean, if you get the receptionist or anybody, be like,
Show us how it's done, Brandon.
Cold calls?
Yeah, just pick up the phone. Yeah. Make your way through it.
In between the Medicare and the health provider, like there are certain metrics that they look at that they want to incentivize, or theoretically, you can approach the RPO, and if you can narrow down the exact risk to something where you have a solution to lower their risk, that would be.
you don't lower risk. They're at risk. What you do is you improve bottom line, top line performances.
You can lower.
That's how you talk.
Potentially lower costs.
That's the language.
Yeah.
Yeah, so we say lower risk. We're a risk management company.
Yeah.
Yeah, it's their job to manage their risk, but you're providing.
But if they price the risk at 10,000 or something, and you say if you apply this and this, you might be able to push down to 8,000. That's how they would. You're calculated.
But you don't necessarily do that for them.
Well, if you want to show that if you have a preventative tool, right, and you want to show, that's sort of the only way to sell it to them, to show that's kind
to show how you've managed the populations that you're responsible for, not how they're going to manage their. I mean, you don't even want to get in that discussion, because why? The VP will change tomorrow, and there goes the risk management philosophy that the VP day before had. Why would you want to commit yourself to those kind of things? No, make non-committal. They're just statements that you can directly control. That's my suggestion to you, because they will come back. And you're talking about a lot of dollars. So if you're doing any risk deals, I suggest you don't. I suggest that you have a escalator in your agreement. Do a 5-year deal. Say first 2 years, just SaaS, whatever your model is. And if you want to get really high stakes, meaning you want to excite your B2B partner, then you could say, okay, we'll do that upside come year 3. Right now, I'm going to save you X dollars and we'll distribute 25% of those savings. The next year, 30%. Year after that, 40%. And then if you're really audacious, you could do a downside, but why would you?
But they're allowed to do that.
What do you mean?
They're allowed to share, yeah.
Of course.
Well, that's great.
Share the share.
Oh, that's fantastic for the system. Then let me just filter back up, you can actually share it with.
Well, that's where it comes down to nuances like the provider even knowing that they have a patient to see.
It's tricky because if there are 4 or 5 programs, they're all addressing cost, and so patterns yours. It's pretty tough.
Yeah.
Performance based is not easy.
Not easy. And think about the Medi-Cal, for instance. The member could change their health plan month to month. So let's try to talk more about the Medicare. Because if you get into the nuances of trying to now track, okay, this patient was in LA Care, now they're in Anthem, Health Net. It becomes a different kind of.
Can you pick your brain on future outlook? I mean, there are 2 hot topics now. You hear the disaster Medicaid for all, right? Like you would have a hospitalization insurance provided for everyone. And then you would have fee for service for whatever you wanted to top up. And then also the new discussion that we're going to run out of money, right? Medicaid in 2022. And there is 2022, the Wall Street Journal yesterday.
2026.
But they have funds, right, allocated. They have, I'll bring up the article. The way I understood it is that they have, because they've been running a surplus previous years.
Surplus?
Yeah.
Explain which line of business.
No, at top level. So
Which one?
you pay if I'm an employee, I pay an SSI and I pay a Medicare each year, right? And that goes to financing the system. And the system, well, from what I understand, they have funds from previous year that they can allocate if they were to run into a deficit.
You might be talking about commercial off exchange.
No.
Honestly,
Okay, so look at because when you say SSI and payroll tax, that's Medicare, right? Well,
Isn't that just like
tax-
going into Medicaid?
So let's talk about the payroll tax, which is Medicare, right? Because you're saying was funded, because not everybody's entitled to Medicaid,
No, exactly.
right? Everyone's entitled to Medicare. No, there's no money.
So what's
The
gonna happen
money-
when they're out of,
Sorry,
your best guess?
we're shit out of luck. What's gonna happen? I don't know. I mean, nobody knows. It's one of the things about this industry. We fly the plane as we build it. We're not as great as Boeing, but we are pretty interesting in terms of how we're managing the costs, because the imminent threat is not salient to the populace. It's not. Because the person who's 51 today, when they hit retirement, the Medicare trust fund is depleted, according to NPR Today Now.
Yeah.
And someone else here at the Biocom shirt,
That's what I'm
she read in Wall Street Journal. So I'm hearing
Yeah.
that the person who's 51 today, I'm not 51,
Yeah.
so, but I've paid a lot of taxes into this payroll thing.
So don't look
And
beyond 6 months, that's
They're
correct.
actually hitting the reserve, they're pulling from the reserve fund. And so, again, I'm happy to have that discussion kind of
So that's the
separately,
reserve fund, they're pulling from a reserve, so there
but
is a
it's
reserve
not
fund.
unlimited.
No, but what's that reserve fund built up? Is that from previous years where they've been running with the surplus?
But think about how you have 10,000 people aging into Medicare daily, and millennials have not been very productive in terms of generating offspring. So you have less dollars going into the fund, more coming out, basic, finance.
Yeah. But so what's gonna happen? Best guess.
Well, that's a discussion.
Run out of money. That's the answer.
Yeah.
So when did the lockbox concept,
That's pretty good.
when did the lockbox concept for Social Security, for example, go away? When did that cease to be in existence?
Lockbox?
Yeah, well, there was this vision or ideal of a reserve set aside based on the earnings put there by the working.
That is how
Like
the
working.
trust fund works.
Yeah.
How Bruce,
Yeah, it wasn't rated, it just simply they aren't taxing at a high enough rate to produce enough revenue to pay all the healthcare bills. The lockboxing is like no more taxes, that was a Bush, and other people have used that since. But they haven't rated it to put it into other things, they just simply haven't been generating revenue. As you said, population has been working the wrong way.
Well, what I mean is there's been when Social Security was first initiated, there were more workers per retired person.
Correct.
At some point, that got upside down. And that's, I think, at least from my thinking, where the reserve, the cash reserve or lockbox idea got started. And at some point, it went bankrupt.
Well,
Did it not?
So that's different. It's a different, but first of all, people are living gigantically longer than they were in the 1940s. So, you get Social Security when you're 65. It was not considered to be your retirement thing. It was a supplement. And you're dead at 68. They had to be there for 3 years. People are living to 77, 78. So unless you have people contributing way past it, I mean, if the idea is Social Security be your last 3 years of life, the thing would be awash in money. There'd be more money than you'd know what to do with.
Right.
But something that was designed for people till they're 68, now we're living to 78, is why that program is upside down.
Right, because Medicare was tied into that came of age, right?
They're different.
that's why
They're different sources of
buckets.
funds, different tax lines. They don't relate to each other.
That's that's one of the things. And what I encourage you to do is kind of like to, again, close, be respectful of everyone's time, is approach the business with sense of urgency. I mean, it's not unlimited by any means. I mean, we're at $3.5 trillion a year exercise, and that's only increasing. We're projected to hit 4.7 in a few years. And so the market opportunity for health tech entrepreneurs is widening. The cost gap is widening. The market dynamics and the threat that we personally face call for solutions that you as innovators are bringing to the market and thinking, okay, well, let me not, think, how can I bring value into this environment? And in order to do that, you need to get your contracts. In order to do that, you need to speak like them. Thank you.
Thank you.
Should we do,
Thanks, Mark.
you and I can sit down one day and do like a cheat sheet with all of it?
Yeah, 100%.
And then the
Like
stuff.
the news
Good job, Alex.
Yeah, this-
And if you want,
I
we
imagine.
can sit down and do the.
It's just so scary.
He said it.